Hello everyone, this is Dr. Sangeeta Chaudhary once again, and I welcome everybody to my lecture class. In today's class, I am going to discuss about hepatic encephalopathy. As I was discussing about various complications of liver cirrhosis, so this is one of the very important and deadly complication of hepatic encephalopathy. Okay, so let's see what is hepatic encephalopathy, how do the patient presents with, and how can you manage a case of hepatic encephalopathy. Hepatic encephalopathy, what is it? It is actually a constellation of neuropsychiatric abnormalities. It is observed in patients with significant liver dysfunction after exclusion of other known brain diseases. That means it is a diagnosis of exclusion. We need to exclude other brain disorders, and the patient should present with neuropsychiatric abnormalities with significant liver dysfunction. So it develops in 50 to 70% of patients with cirrhosis. That is very important, and as I said, deadly or dangerous complication of liver cirrhosis. So let's talk about the pathophysiology. What happens in hepatic encephalopathy? Why somebody develops neurological or neuropsychiatric manifestations? Whenever there is liver cirrhosis, there'll be inflammation, there'll be bacterial translocation in the gut, and there'll be release of vasoactive mediators. Now, all these will lead to splanchnic and peripheral vasodilatation. Because of the vasodilatation, okay, there'll be opening of the portosystemic shunts or collaterals. So there'll be hepatocyte dysfunction, and ultimately all the toxic toxic substances including ammonia will bypass the liver and it will reach the systemic circulation because of collaterals and all and hepatocyte dysfunction. Now, because of vasoactive mediators, there will also be increased blood-brain barrier permeability. So ultimately this ammonia will reach the brain and it will result in edema. Okay, brain edema. It will result in astrocyte swelling, and there'll be alteration in the neurotransmitter and receptors. Okay, there'll be increased GABA and there'll be altered brain glucose metabolism. So all these will lead to the clinical manifestation of hepatic encephalopathy. So the major thing in the pathophysiology, we need to remember that because of portal hypertension, okay, there'll be opening of portosystemic shunts and all the toxic materials, mainly including ammonia. Okay, ammonia is toxic to brain, so ammonia and other toxic materials, they will bypass the liver and they will reach the systemic circulation, and because of increased blood brain barrier permeability, they'll enter the brain, resulting in cerebral edema, astrocyte swelling, and different alteration in neurotransmitter, which will ultimately give rise to the manifestations of hepatic encephalopathy. Now, there are various precipitating factors for hepatic encephalopathy which we need to keep in mind, because if there are these precipitating factors in a particular patient, we really need to manage or take care of the precipitating factors so that the patient doesn't go into hepatic encaph. If a patient has gone to hepatic encephalopathy, though he will recover with treatment, but the lifespans become short. Okay, the prognosis in a patient with hepatic encephalopathy is grave. So what are the precipitating factors? Gastrointestinal bleeding is one of the important precipitating factor. Infection or systemic inflammatory response syndrome, renal failure or electrolyte disturbance like hypokalemia and then hyponatremia, all this can lead to hepatic encephalopathy, precipitate hepatic encephalopathy. Use of psychotropic drugs, increased protein intake, okay, increased dietary intake of protein, and then constipation, again one of the very important precipitating factors of hepatic encephalopathy, and 20 to 30% cases the precipitating factor will be unknown. So these are the major precipitating factors of hepatic encephalopathy we need to keep in mind, and we really need to be vigilant for these precipitating factors. Hepatic encephalopathy can be graded. Okay, the grading system of hepatic encephalopathy is known as West Haven criteria. Okay, this is West Haven criteria or grading system. As per the grade, okay, the manifestations can be divided into intellectual function, impairment of intellectual function, and impairment in the neuromuscular function. Okay, in grade 0 everything will be normal. Okay, then comes minimal or subclinical hepatic encephalopathy. Examination findings will be normal, but there will be subtle changes in work or driving, and there will be minor abnormalities of visual perception on psychometric or number test. Now, in grade 1, what happens in the intellectual function? There will be change in the personality of a patient. There will be attention deficit, patient will become irritable, aggressive, and the patient may have a depressive mood. Okay, on examination of neuromuscular system, there will be tremor and incoordination. In grade 2, what happens? There is alteration in the sleep-wake cycle. The patient will sleep more during daytime and less during nighttime. There will be lethargy, mood and behavioral changes, cognitive dysfunction. On examination in the neuromuscular system, there will be hysterexis. This is also known as flapping tremor. Okay, hysterexis is also known as flapping tremor. I will show you what is flapping tremor when I take clinical classes. So hysterexis gait will be tachyc gait, and there will be speech abnormality. Speech may become slow and slurred. Grade 3, what happens? As somebody progresses from 0 grade to grade 1, grade 2, grade 3, there is more impairment of the intellectual and neuromuscular function, and the prognosis becomes grave. Now, grade 3, there will be altered level of consciousness, confusion, disorientation, and amnesia. There will be muscular rigidity on examination, nystagmus, clonus, Babinski sign positive, and hyporeflexia. Okay, and in grade 4, the patient may go into coma, stupor and coma. Okay, and they may be unresponsiveness to noxious stimuli. Okay, once they're in coma, they'll be unresponsive to various stimuli. So this is about the grading system, West Haven criteria for the grading of hepatic encephalopathy, starting from 0 grade, then minimal grade. Okay, 0, minimal, then 1, 2, 3, 4 gradings, right? So how do you diagnose a case of hepatic encephalopathy? Okay, psychometric tests can be done in the initial grades of hepatic encephalopathy. When there is not so many clinical manifestations are there, it can be diagnosed with psychometric analysis or psychometric test for neuropsychological assessment. Okay, neurophysiological testing, EEG, electroencephalogram. EEG means electroencephalogram, evoked potential. This can be checked for, because they'll give specific findings in case of hepatic encephalopathy. Neuroimaging, we can do a CT scan, we can do MRI of brain. Okay, then MRS, then PET scan can be done. These are mainly done to rule out any other causes of this neuropsychiatric manifestations, where the patient is having any other CNS diseases or dysfunction or not. So neuroimaging mainly helps in that, to rule out other CNS diseases. Blood ammonia level is very important. The ammonia level in the blood will be very high, because it will bypass the liver via the portosystemic anastomosis. So these are the investigations we can do to confirm our diagnosis of hepatic encephalopathy. Though the diagnosis of hepatic encephalopathy is mainly a clinical diagnosis. Lastly, the most important part, management of hepatic encephalopathy. How do we manage a case of hepatic encephalopathy? As I was talking about the precipitating factors, it's very important that you identify and treat the precipitating factors. Okay, rule out other causes of encephalopathy. Encephalopathy can be because of hepatic, it can be uremic encephalopathy. Encephalopathy may be because of many other metabolic diseases or endocrine diseases. Supportive care is very important. We need to support the patient. Supportive and symptomatic care is important. And specific additional measure. What are the specific measure we can do? Protein restriction. Okay, dietary protein restriction is very important, because as I have already mentioned, protein rich diet can precipitate hepatic encephalopathy. So protein restriction should be done. Okay, Lactulose or lactitol is very important from the management point of view. They are non-absorbable disaccharide. They should be prescribed so that the patient passes stool, loose, semi-solid loose stool at least 3 to 4 times a day. Okay, passage of stool, clearance of bowel is very important to manage a case of hepatic encephalopathy. Gut sterilization is important because all the protein diet will be acted upon by the gut microbiota, and they will result in formation of ammonia. So gut sterilization is important with rifaximin, metronidazole or vancomycin. These days the most preferred drug is rifaximin. Then alpha glucosidase inhibitor, they are off-label use, and probiotics can be used. Zinc LOLA. LOLA is L-ornithine L-aspartate. L-ornithine L-aspartate is an important factor, or I should say part of the biochemical cycle, okay, where ammonia is produced. Flumazenil and albumin dialysis can be done. So these are some some ways to manage a case of hepatic encephalopathy. Now protein restriction, as I was talking about, limiting protein calorie intake is not beneficial. Vegetable and dairy proteins are preferred to animal proteins because of more favorable calorie to nitrogen ratio. And branch chain amino acid supplementation may improve symptoms modestly, but the benefits are not sufficient to justify it. That means use of branch chain amino acid, actually some of the clinician they do, but there is no specific or there is no proven benefit for the use of branch chain amino acid. I was talking about non-absorbable disaccharide, that is lactulose or lactitol. They are the cornerstone for the management of hepatic encaph. They are metabolized by the colonic bacteria, okay, to byproducts which reduces intestinal pH and thereby reduces ammonia absorption. So absorption of ammonia will be less amount of ammonia will go to the blood and then to the brain. Side effects are less. Side effect may include abdominal cramping, flatulence, diarrhea and electrolyte imbalance. And it can be given in the form of enema also. Orally also we can give in the form of solution and can be given in the form of enema as well. Oral antibiotics. Okay, oral antibiotics are used as second line agents after lactulose in patients who are intolerant of non-absorbable disaccharides. Okay, neomycin is not recommended these days because of ototoxicity, nephrotoxicity, but previously was used. Rifaximin is the mostly used drug in case of hepatic encephalopathy these days. It is approved by the FDA for chronic hepatic encephalopathy in doses 400 milligram orally 3 times a day. Okay, metronidazole is also reported to be effective in small trials, but data is insufficient. So we can use rifaximin and sometimes we can use metronidazole as well. Lactulose is accepted as the initial drug of choice in all patients, irrespective of the grade of hepatic encaph. Okay, so irrespective of the grade of hepatic encaph, lactulose should be prescribed in all patients of hepatic encaph. And rifaximin may be an add-on therapy to lactulose to be used in higher grades of encaph, grade 2 onwards. Okay, in grade 3 and 4 hepatic encaph, lactulose enema can be considered based on patient's condition, because grade 3 and grade 4 they will not be able to take orally because their consciousness level will be altered. They may be in deep coma, so we may use enema depending on the patient's situations. I was talking about alpha glucosidase inhibitor. They inhibit intestinal absorption of carbohydrates and glucose, enhance delivery to the colon. The ratio of saccharolytic to proteolytic bacterial flora is increased and blood ammonia level is decreased. That means saccharolytic bacterial flora is increased, and since there is a reduction in the proteolytic bacterial flora, the blood ammonia level will be decreased. I was talking about LOLA, that is L-ornithine L-aspartate. Okay, it is substrate for glutamine and urea synthesis. So LOLA leads to reduction in serum ammonia as well as improvement in the clinical manifestation of hepatic encaph. What is the dose of LOLA? 20 to 40 gram a day. Infused LOLA, okay, ameliorated postprandial increase in ammonia following oral protein loading. Okay, that is important. So LOLA can be used to reduce the serum level of ammonia. Probiotic I was talking about, though off-label use, they are used to modify intestinal flora and diminish ammonia generation. They may be beneficial in mild hepatic encephalopathy. Lastly, what is the management option we have in our hand when nothing works for the patient? Okay, last thing we can do is we can advise for liver transplantation. Okay, so definitive intervention for liver failure with a swift return to a normal mental state. So liver transplantation can be advice for as a last resort. So thank you so much for attending the class. I hope this class was helpful, and I hope now you can really identify the cases of hepatic encephalopathy and you can really manage a case of hepatic encephalopathy. Thank you so much.